Thank you, Chairperson, for kind words of introduction. Thank you, Jyoti, and the complete scientific and organizing team for giving me this prestigious oration. What I am going to talk in next 25-30 minutes, why we should talk about primordial prevention. We are talking every time only about the primary prevention. So can we think of diabetes in a primordial prevention, that diabetes should not occur? We know that this dreaded disease is shaking our foundations. We have 101 million people with diabetes. Diabetes incidence is increasing. Global, it is 45%. India, it is increased by 123%. Recent paper of Rakesh, it's shown that in India, we have younger and younger persons below the age of 35, and here shown even below the age of 25 only. Also, new cases of diabetes are increasing, and that's the reason. The increasing incidence is the reason for increasing prevalence. And what we are trying is just prevention will not decrease the number of people with diabetes unless we think of something primordial prevention of diabetes. So when we are talking about the primordial prevention, we have to intervene very early to prevent diabetes. That is what we can think of. It's not like just someone who has developed already diabetes or a pre-diabetes, then you call it primary prevention, but we have to intervene very, very early if we want to do the primordial prevention. This data you must have seen multiple times. In 2021, IDF data is showing that all over the world, the number of people with diabetes are increasing, mainly more from Southeast Asia, but definitely Western Pacific region as well as Africa. Also, we are seeing a lot of people who are developing diabetes. This paper we talked long back, Diabetes-Free India, 2030. And this was what, when we had given this white paper at that point of time in 2017 to our President, Honorary President Dr. Mukherjee, that what was it? That no one should have a diabetes after 2030. People were laughing that what type of paper you are talking of. This is what we mean is the children born after 2030 should not develop diabetes, or they should not be exposed all those diabetogenic factors in their lifetime to become diabetes. For type 2 diabetes, we are not talking of SIDD, we are not talking of type 1 diabetes, we are talking that something which can be preventable and how it can be prevented. We had given in this white paper that first we have to counsel these young girls, counseling these young girls to eat healthy food and stay physically active will lead to an increase in their muscle mass. That was our primary aim of these young girls who are not even teenagers. They are below the age of 10, 8 or 9. That was first thing which we want. Why we want them? They should become healthy mother after 15 years, after 10 years. So when we thought of in 2017, a diabetes-free India by 2030, the idea was that you start working on a child, female child at the age of 7 or 8, another 12, 13, 15 years, they will become mother. And after 2030, if we will just work on all these young girls, probably when they will become mother, they will not give a birth of a child who will have a diabetogenic risk factor. That was the idea of the diabetes-free India can be thought of after 2030. So we have to create them a healthy mother and healthy child. These children who are born healthy, if they will be, even they should continue to remain healthy school kids. And that was the other idea. They should be intervened at that stage also. And then they should become healthy adolescent or healthy youth. And that will make them a healthy adult. And that will be diabetes-free adult. Or you can see they are metabolically healthy. They should not become a person who is metabolically unhealthy, who is at the risk of developing diabetes or a cardiovascular disease. This was a concept which we had given to the government of India, to the Honorary President of India, and at that point of time to the Health Ministry. We met multiple government agencies and tried to do the advocacy for improving the quality of life and to create a healthy India. As we know, this paper which has been published in 2021, the rising prevalence of type 2 diabetes in our country, we have 101 million, but if you see the other metabolic conditions in our country, whether you talk of central obesity, you talk of dyslipidemia, you talk of pre-diabetes, we have all those, and they all have common reasons. They have all common origin. The metabolic, all these problems are having a common soil. Why they are having? Some of them are developing diabetes, some of them have still abdominal obesity, and tomorrow they may develop diabetes, if not diabetes, straightway coronary artery disease. Now this was in the same ICMR paper, which is talking about the prevalence of diabetes. As we know that 40 or 45, in 40s, we are seeing sudden increase in diabetes in our country. But even this increase is starting in the 20s only, from 25 to 39. Unluckily, still ICMR is saying that below the age of 30, they need not to screen them regularly for the sugar. But recent paper of again Rakesh, which was published in our International Journal of Diabetes and Developing Countries, which is talking that even we are seeing the people with newly diagnosed who don't have any symptom, type 2 diabetes below the age of 25, below the age of 30 and below the age of 35, which is also very, very high. And probably now this is the time, after that the Anup Mishra had also written one paper, now this is the time that in India, rather a person with all adults above the age of 18 should be screened regularly for sugar and screen them for diabetes or early incidence of diabetes. This one more very interesting paper of IDF, which is talking of that in Southeast Asia, we have highest hyperglycemia in pregnancy. So the HIP, or you can say the early GDM, we have highest number of people in the world. And Southeast Asia, I mean, it is Indian subcontinent. It is the smallest region of International Diabetic Federation, which is India, Pakistan, India, Bangladesh, Sri Lanka, Nepal, Maldives, Mauritius. These are the 6 and 7 countries. So I mean, primarily it's in the Indian subcontinent. So when you are talking of Southeast Asia, where the hyperglycemia in pregnancy is very high, you can see in compared to other region, in compared to North Africa, you compare with the South American region, or you compare with MENA region, where even the number of people with diabetes are very high, but hyperglycemia in pregnancy, and this is very important. I will come back to you that you know why I am talking of hyperglycemia in pregnancy. One side is very high, and other side I am showing you the number of people who are increasing in our country with diabetes. The other very important reason why we are becoming more diabetic. One side we are talking of a making healthy mother because we want a healthy child, but those who are healthy adults, even they are becoming unhealthy because of this affluent lifestyle, and that we can call it affluenza. We are becoming more affluent, we have become more sedentary, we are eating, our eating habit had become more of a carb, refined carbs, we are eating more fat, increasing in our central obesity, and this typical condition we can call it, we are becoming more affluent, and this new virus infection we can call it affluenza. It's a new influenza that we can say that India is today suffering from this disease called affluenza. Now this is very important slide, that a life course approach for a prevention of NCD overall completely along with diabetes at each level. We have to intervene. There is a possibility of prevention, even someone at the level of fetus. So what you can do with the fetal life, because if we can improve the maternal nutrition, if we make sure that mother is healthy, if we make sure that she is not developing hyperglycemia in pregnancy, or before she becomes the pregnant, she is not a person of a PCOS, or she is not an obese person, probably in a fetal life also we can have an intervention. It means you are going to have a newborn which will be more healthy. When you will call it healthy, I will come back to you for that. In infancy also, the nutrition of that infant who is a newborn child or below the age of 5, even we can work out also to make him more healthy, to have increase in growth, which is a linear growth, not is increasing in fat mass, not is increasing in just increasing the weight of that. In adolescent, again decreasing the obesity, the lack of activity, which is a major reason, so we have to improve, and that we have to increase. That is what we can do in school education, and they should not indulge in the smoking and alcohol, all those type of habits too. In adults' life, we have to create an environment and an ecosystem where they can have a healthy life. They can remain more in a standing position. They should do more workout. They should become more physically active, and chances of becoming more of central obesity, increasing their muscle mass, that should increase, and their central obesity should be decreased. So there is a possibility of prevention of diabetes or prevention of all non-communicable disease at every stage. Even they may or may not have the risk factor, but definitely if today we intervene, we can prevent them to become the diabetic or with a person with coronary artery disease. If we will not be doing just thinking they are healthy today, tomorrow they are going to develop all those problems. So what we are doing is at present we are looking only for those people who are already having a pre-diabetes or on the risk of developing diabetes. We have Indian diabetes risk score, but we are not considering all our normal population. Rather, I will say all of us, Southeast Asian population are at the risk of developing diabetes. So if we are thinking of primordial prevention, we have to think for our population, we have to make normal. So I mean, whatever who are we just now, we have to make the next generation very healthy, and they should not develop diabetes in their lifetime. That we will call primordial prevention, not the primary prevention which we are talking of. So all the prevention study, if you talk across the world, they have talked only for primary prevention, mean those who are already at the risk of developing diabetes or those who have developed already diabetes. And then you try to intervene them either with the exercise or with the metformin or with the lifestyle. But when we are talking of primordial prevention, we are talking for healthy, normal population. The global map, this is very interesting data with the World Health Organization. If you just see the data, I mean this IDF, this World Atlas, you will find the India or Indian subcontinent, the Southeast Asia population. We are very typical. We have our children which are newborn, their birth weight is very low, which is less than 2.8. But if you see the North America, if you see the North Europe, even if you see the African population, which is again after the Southeast Asian population, probably the low birth weight may be the second highest, but even South America and Australia, you will find the average birth weight of them is 3.3, while the average birth weight of an Indian newborn is around 2.8 kg. And this is the, we are in such a paradox condition that one side we are developing highest number of non-communicable disease, and other side we have undernutrition, we have low birth weight. So in the world we are having the low birth weight and malnutrition, undernutrition below the age of 5 years are highest. And other side we are having highest number of type 2 diabetic patients also. So such a paradox is there. One side undernutrition and other side we are having people with highest number of diabetes. So there should be some correlation also with this. This very interesting study done by Dr. Yagnik, he had shown that a newborn in a Pune, he had shown that his birth weight is 2.8 kg. And even with a 2.8 kg birth weight, his fat percentage is more than 25%. That means he is a thin fat boy. Even the birth weight is 2.8 kg. While a Caucasian newborn having a birth weight of 3.2 to 3.3, which is a white Caucasian in UK born with a 3.3, and still the fat percentage of that Caucasian, here you can see that 3.2 is around 15 to 18%. While in an Indian newborn with a low birth weight, still the fat percentage is higher, which is almost like 25 to 30%. So by birth we are lean, but we are fat Indians. So you can say that we are lean, fat Indians, and a thin fat Indian concept which is given by Professor Yagnik. Long back he has worked on it, and it was published in 2002 to 2003. So what happens in an Indian scenario? Very Indian typical scenario, because of either you can say a poor maternal nutrition, a lady with a PCOS, or because of hyperglycemia in pregnancy, or she is malnourished. Both the condition will lead to either very low birth weight child, or even if she develops GDM, because of instead of vaginal section she is on cesarean section, they are getting low birth weight child. Because of increasing number of complication of pregnancy, more cesarean sections are done, and it is normally not full-term baby, and we get the children, I mean newborn, between the 8 months to 9 months, they are low birth weight baby. And then what happens, the complete family tries to feed that child, and they want that child should develop faster, and they try to increase the fat percent of the child, not the linear growth. The complete family is behind the child to give them more diet, and which is not nutritious. It is not like that we start giving them a milk which have sugar. Why we start giving the sugar at the newborn which is only 3 months or 6 months? It is not required, but yes, we start giving, and we give all fatty food to not increasing his linear growth, rather is increasing the fat part of it. And then you can see the early adolescence, or even the early adulthood also, they start increasing their weight. And this is not even in the upper middle class or middle class. Even if you see the lower middle class, we have taken this photograph with a person who is working in the field. Still you can see the central obesity, you can see the abdomen, the protruded abdomen, that is what commonly seen, and that leads to increasing prevalence of metabolic syndrome across the country. This thin fat Indian, the other concept which he has given, not only for the low birth weight from the childhood with high fat percentage, which he called about the thin fat Indian, but that remains true throughout the life. Many of us inside this auditorium, you will find their BMI maybe 22 or 21. But if you go and get your BC, I mean body composition analysis machine is right here in JPEF, in exhibition area, you will find your fat percentage will not be less than 25%. Believe me, not a single person in this auditorium will have the fat percentage of less than 25%. The same what Yagnik had done, he is not doing exercise, but you can see he looks very lean and thin. And he compared himself with a Yudkin, whose fat percentage was only 9%, while the Yagnik fat percentage was 21.2%. So even a BMI of the normal person with the fat percentage of 9.1, Yudkin against a person who looks very lean with the absolute normal BMI as per the Indian standard, without even the central obesity also, his fat percentage was 21.2. So the Indian phenotype is very typical with a thin muscle mass, with less muscle mass, sarcopenic, with more of a fat, while in a European phenotype, it is more of a muscle mass with the less amount of fat in that. And that's the reason we are developing diabetes, which is almost 1 decade, or you can say even 2 decades earlier. We had shown the data recently, as I told you, that Rakesh had published the data that we are developing diabetes in 20s and 30s, while Europeans are developing diabetes in 40s or 50s. The same way, we are developing diabetes at a lesser BMI. We show the BMI of 25. No, we are even developing diabetes in 23 and 22. They are not type 1 or severely insulin deficient. They are typical type 2 diabetic patients, we are saying. The mid-arm circumference of an Indian is less, 20% less in compared to Caucasian. And that's the reason the waist hip ratio, the insulin resistance is high, fat percentage is high, and subtype, which is shown in Mohan paper, that we are typically insulin deficient from the early and highly insulin resistance because of higher visceral fat mass. And this is what a typical thin fat Indian concept. So what we can do? The child who is born, the newborn, instead of increasing his adiposity, if we work on his increasing his lean muscle mass, if we increase the length of the child, not the fat part of it, probably we can decrease the risk of diabetes. And if we increase the adiposity part of it, the risk is always going to increase for that. And the life cycle which is going on in India at present, that's very typical, which is like that, what a baby, either a large or a small baby, which we are getting because of more cesarean or because of poor maternal health, whatever the reason which may be, then this girl child is becoming overweight. She develops all sort of a PCOS, obesity. Because of malnutrition, we are not making healthy mom. We are creating a pregnant lady which is not healthy, which she is having again hyperglycemia in pregnancy, and she again develop either GDM, and again a low birth weight child with a higher fat percentage is going on increasing, and which is increasing the risk of diabetes throughout the lifetime or increasing the metabolic risk. So the womb may be more important than the home, and that we have to create if we want to create an environment where we can think of that a diabetes-free India. Maybe after 10 years, maybe after 20 years, or maybe after 50 years, we have to work on healthy moms. And healthy moms are going to give us healthy baby, and that will change what we are having diabetes today, maybe after 20 or 30 years. Even this low birth weight child is not only responsible for increasing metabolic syndrome or diabetes in adulthood, but they are also increasing the risk of cardiovascular disease in offsprings too. There are data, even they are also bad for the lung health. Those who have low birth weight child, and then they in adulthood, they develop more of a asthmatic problem, more of a bronchitis, more of a COPD, and all sorts of lung disorders too. So it's not only only for the metabolic syndrome increasing risk of that, but for other issues also. So the solution for prevention of diabetes is, before we talk of target lifestyle of adolescent and adults, all typical talk of prevention of diabetes, we talk of only lifestyle. We talk of lifestyle prevention for all those who are adults who are already at the risk of developing diabetes. They have already developed central obesity. If we want to really prevent the diabetes, target maternal malnutrition and GDM. That should be the first target which we should have to have a healthy baby in the future. And then we should target childhood overnutrition obesity. That's the pediatric obesity. That's our second thing. And definitely The third, which we have to work on it, the lifestyle of the adolescents and adults, because we want to prevent the diabetes, metabolic syndrome, and that we call it rather secondary prevention. The primary prevention is still the targeting the maternal malnutrition or childhood overnutrition. So we have to work at every age group. As I have shown in the data that even a child is newborn between 0 to 5, promote breastfeeding, avoid sugar, responsive feeding. Just not the mother should keep on, feed the child, rather than it should be on responsive feeding when child asks for the food. The controlling the screening time. I am seeing now even a 2-year-old child or even 1 year, the mother gives the phone to the child just to keep on seeing, and that is what is happening. The risk assessment for these, the pediatrician are to be educated, is appropriate physical activity, and that we have to teach the pediatrician. Pediatricians are mainly working on the weight of the child. They are forgetting the low birth weight child. If you just keep on feeding, the child weight will increase, and that is a disproportionate, and that will increase the risk for metabolic syndrome in adult life. Sleep hygiene and a growth monitoring age per birth weight, and this is require lot of education to the pediatrician also. The school-going child, that is between the age of 5 and 12. A health science booklet in a school curriculum. When I had given that paper in 2017 to the Honorary President of India, at the same time we made the NCRT, the Government of India, for improving the education in school. And what we asked, that we should have a health science as a booklet, as a book from class 5 to class 9. Not as a few chapters in social science or few chapters in their biology book. No, it's a separate book on a health science, and it should be a part of curriculum. If we educate a child regarding different aspects of the health, not only it's related only for the non-communicable disease, it could be infection, it could be on vaccination, for all aspects of health, there should be a book, and that child will carry throughout his life, because he will educate, he will understand that what he has to do in throughout the lifetime. The growth monitoring again in the school, the healthy diet in school canteen, which is very important. The school teacher should be also taught about the healthy diet. The discourage fast food everywhere, physical activity and promoting sports, and screening for obesity. And those children who are more physically active, those who are remaining, more physically active and increasing in muscle mass, they should be given some sort of a promotion. They should be given, in their, only the school marks is considered, for their grade, for their, it should not be like that. They should be also given those who are more active. There is extracurricular activity, definitely they get points, but they should be given more, sort of an encouragement from the school too. The teenagers and adolescents, they are high risk for developing obesity. Now you can see in all, class 10, 9th, 11th, or even the young students who are going in college, we are seeing a lot of children, they are becoming obese. Counseling, they need peer support, digital health engagement, nutrition workshop, lifestyle choice campaigns, and community involvement and mental well-being. That is what we should try to do for these children. The young adults, now these are the adults who are after the teenage group. The reinforcement of all those healthy habits which has been taught in school or in the college in their life, education on obesity and diabetes, comprehensive health monitoring, fitness challenge and incentive. And this incentive biggest is that standing culture. I could not see any doctor in India who is practicing in a standing position except Dr. Jyoti Dev. He is seeing all his patients while standing only, and he remains throughout the day, and it is the I can say his raj of remaining so healthy. So, this type of activity we should keep on doing, and this healthy lifestyle and a standing culture. If we start in our office work also, I mean, most of the office, what they say that I am remaining all the time sitting, from 9 to 5 because my job is like that. But the same desktop can be put on a standing, and he can do all his work while standing also. In between, when he can sit in between. So that sitting should be in between, rather not continuously. That type of a culture we have to create. A culture of more standing and an environment modification will help for these young adults not to develop central obesity, and probably that will help them not to develop diabetes too. The middle-aged adults, now these are the 45 to 65. Now we have to work, as I told you, at every age group. We don't know whether some of them might have developed diabetes. Even in the 20 to 45, they all should be screened. Not only for diabetes, also for cardiovascular disease. Also for how many of us are getting themselves for lipoprotein A, for their LDL cholesterol, and for their patients also. So I mean, we should screen our patients, ourselves, our family members for all those risk factors, for diabetes, coronary artery disease, metabolic syndrome, regular health checkup, exercise to prevent sarcopenia. That is the most important thing. Rather, as I told you, from the childhood we should start talking about the muscle exercise, but it should increase highest in the age those who are they have missed the bus because they could not do in their 20s and 30s. Today you and me who are in their 40s or 50s, we should start working that we should prevent our sarcopenia. Again, nutritional counseling, culture of more standing, and environment modification. Environment modification means the government, the municipality, they should create a system where they can go for walk. The gym, public gym, these all things should be available. You know, the walking streets and all those things, that we should make more friendly so walkers and the pedestrian can do more activity in compared to they have to take the two-wheeler or four-wheelers. Above the age of 65, I mean, we are talking today, so there are so many people who are already sarcopenic, who are already developed diabetes, already having coronary artery disease. So we have to work for those elderly people also, not only for their monitoring, for preventing complication, for their secondary and tertiary prevention. So when we are talking of primordial prevention, we have to talk for the making healthy mom. But those who are already at the age of 60 or 65, or they have developed complication, we have to continue to work for them not to develop complication. If they have developed complication, further how we can prevent those complications. And today, in the era of these newer drugs, we are primarily not glucocentric. Our approach is now complication preventive approach, and we all work for those drugs which are helping our patients for preventing complication, but we are forgetting sometimes like sarcopenia, which is increasing, muscle strengthening exercise has to be increased, and we have to give them a, you know, the physiotherapy that should be a part of life for all those who are above the age of 65. To improve the health of every female child, that's the primary aim of it, for a primordial prevention. And for this, we will say it's a multi-pronged approach. It's not just one thing which we can do. We have to think of maternal health, maternal nutrition, and in utero environment to have a healthy baby. But other side, we have to also work for urbanization, for an unhealthy lifestyle, for a sedentary lifestyle, for an unhealthy diet, lack of exercise and stress. So, you know, one side you are working on a maternal health, and other side you are also working on a urbanization or other all risk factor, environmental risk factor which we are providing to our adults or our population to develop diabetes. And this urbanization, unhealthy diet, if we work on it, we can prevent obesity, we can prevent conversion of pre-diabetes to diabetes, and we can prevent complication. If we start working on a maternal health, maternal nutrition, and in utero environment, probably we may have the next generation with normal birth weight, a healthy newborn, with less insulin resistance, because more the visceral fat, higher the insulin resistance, and less risk of diabetes and obesity in their lifestyle. And this will have a generation impact. I mean, 2 generations we are working. Today we have to work for those young female children to make them a healthy mom for after 15 years, and probably for next generation we are working now. And those who are already here, we have to work on the left side to get them not to get the obesity. So these are the 2 generation impact. If we can work on it, maybe in another 25, 30 years, 50 years, we can think that incidence and prevalence both are decreasing. Not just that prevalence and the incidence both are decreasing. To conclude my talk, you invest in health of female child. I mean, that is the most important point. If it's from advocacy point of view, from the government point of view, and from the doctors and all organizations, we should invest more in a health of a female child. Inculcate the healthy habits from early childhood. From the early childhood, we have to create the habits of a healthy lifestyle. The school, all the corporates, all the government system should be also, and the health should be one of the criteria for them. Above the age of 45, definitely regular health checkups and prevent the complication. Above the age of 65, prevent the sarcopenia. And on the left side, which is a beautiful, you know, in a diagrammatic form given by Rakesh, that, you know, how we have to work on it. And even with the one, this photograph, you can understand that how we can prevent the diabetes and how can we primordially prevent the diabetes. This paper, which is again when we have written, we have made the President of India from the Diabetes India. We had given the paper, we had submitted this paper to the Health Department also, and the Honorary President of our country also talked to us regarding this. Yes, the idea, she liked it. She had originally given us only for 20 minutes, but then she sit with us for more than 45 minutes. She understood and complete presentation and full paper she asked us to read, and then she immediately called the health secretary also. And then we met the health secretary and we had given our paper to her also. So we can change the natural history of type 2 diabetes. And definitely in India, we can completely, primordially, we can prevent the diabetes. And let's close the door for diabetes. This is the Teen Darwaja of Ahmedabad, but I'm sure all big cities in India, we have these typical type of gates. And let's close the gates for diabetes. To know more about prevention of diabetes, we have World Congress of Prevention of Diabetes, which is coming to India. First time in India, we are going to host this meeting along with DRS at Mumbai. And please block the dates who are more interested in field of diabetes prevention. With this, I thank you very much once again to Jyoti Dev, organizing team, scientific team, and chairperson for giving me this wonderful opportunity. Thank you very much.
Thank you, dear Banshi sir, for that excellent and exceptional talk. It was VC Matthew Roy Memorial Oration. And Banshi sir is undoubtedly one of the most respected personality in the field of diabetology in our country. Although it was an oration, it contained so many take-home messages, as all of you know, that one of the greatest things that we can do as far as the management of diabetes is concerned is the primordial prevention. As SARS told, GDM, if we manage GDM adequately, we are managing diabetes in a primordial prevention way. So we were really blessed to have you here,
Thank you,
sir. Thank you, and for that wonderful oration. Thank you, sir.
Thank you.